Hi everyone, we're happy to have here today Dr. Peter Henke. He is the James C. Stanley Professor of Vascular Surgery at the University of Michigan. He graduated from the University of Wisconsin School of Medicine and finished his general surgery residency at the University of Louisville, where he was honored with the Children's Award for Personal Scholarship and the CM Award for Best Resident Paper in the year 1997. He joined the University of Michigan for his vascular surgery fellowship and joined the faculty in the year 2000. He is the past chief of surgery at the Ann Arbor VA, past president of the American Venous Forum, and past chair of the PVD Council for the American Heart, and current co-chair of the Vascular Discovery Committee. So, Dr. Henke, could you elaborate on the latest advancements in risk models for DVT and how they have been integrated into clinical practice?
Yes. Thanks so much, Oscar, for the opportunity. Happy to be here today. Risk factor assessment for venous thromboembolism risk has been, I'd say, popularized over the last couple decades, in part because of Joe Caprini's work with the Caprini risk factor assessment model. There are some other ones such as IMPROVE as well, which is a little more for medical non-surgical patients risk. I would say from the Michigan example, the scoring sheet, Caprini risk score, and at our VA is part of the intake. And so patients who are admitted to the hospital all have to get a risk score assessed, and then there's some suggested either lower acute or lower intensity VT prophylaxis, such as sequential compression devices, or low molecular weight heparin for mid and higher risk, or both for very high risk patients. So it's a default application of applying this risk factor model for all patients who arrive. The advancements are really a little more attuned to making sure defect-free prophylaxis is given after the VT risk assessment score is determined. So skipping doses or patient refusal, patients not wearing sequential compression devices, these are all things that need a little more intensive study. Also patients who have the so-called breakthrough VTE, where they're maybe on prophylaxis but then suffer VTE, or select very high-risk group patients who we still don't know the best way to prophylax to prevent that. So predictions are, severe infection, ongoing cancer, and the like. Last thing I'll say about risk factor assessment is that it applies in hospital, but with so many patients leaving early, there are a subset of patients who should be prophylaxed once they're home, especially if they're not very mobile. Post certain colectomy, inflammatory bowel disease patients may be applicable for an extended prophylaxis. Same thing with a major cancer resection may also be applicable, because at least about 2/3 of VTs occur if you follow them for 90 days after the inpatient hospitalization episode.
Perfect. Moving forward, you have been worldwide recognized for your research, which has a strong focus on translational aspects related to venous thrombosis resolution. Can you discuss some of the most promising findings on translational research efforts in DVT?
Yes. So I'll first comment a little about what we have to use here, which is animal models typically. So that's most commonly the murine model. And what that involves is either ligation or stenosis of the vena cava. That gives us tissue in which we can then analyze. The rat is also used in this regard. But it gives us consistent thrombus and vein wall tissue to analyze. With regards to the thrombus, Dr. Wakefield, my prior boss and mentor, when I was in the lab, was characterizing this in the sense of the neovascularization of thrombus. So whether you can add an agent or a molecule or chemokine or something to accelerate neovascularization of the thrombus to allow it to resolve may be a long-term potential therapy. The direct mechanism of whether neovascularization of the thrombus does allow it to resolve is likely, but it's mixed in the literature whether that's totally a mechanism for it. In terms of, I'd say, the most promising things that we've studied over the years are immunomodulation of leukocytes to help the thrombus dissolve more quickly. And so we're looking at ways to accelerate or prime the monocytes or treat the monocytes where they may release more plasminogen activators would be one, matrix metalloproteinases, other pro-inflammatory chemokines to call in other cells. The downside of that is the inflammation that resolves. So that's kind of what we're trying to look at over the last decade or so. And I'd say most recently, looking at ways to then, once the clot is formed and kind of is over the acute inflammatory period, then try to allow it to heal more quickly. And there are some nanoparticle agents that look very promising in this regard. So that's currently what we think may be the most promising therapy, because the current therapy, which I didn't mention, is anticoagulation for thrombus. And so that always has the side effect of bleeding. If you use a clot-busting agent such as TPA, that has even a higher bleeding risk. And then there are mechanical ways to clear the thrombus, but whether that impacts the vein wall long-term is unclear.
Focusing a little more on the vein wall injury, which is a critical area in your study, what are the most significant challenges in understanding vein wall response of thrombosis, and how might overcome these challenges impacting the treatment of DVT?
Yes, so that actually is the vein wall is a bystander, so to speak, to the thrombus as it resolves, and like I mentioned, the inflammatory process that occurs, and again, quite akin to wound healing. And it's a fibrotic disease. So there are, throughout the human body and organisms, fibrosis is a post-injury response. It's hard to reverse that, so prevention or attenuation of it is really the key, I think. And so vein walls thicken over time. They get collagen and matrix-rich tissue that develops, and that again is dependent on primarily monocyte macrophages and whether they're more of a pro-inflammatory phenotype or a pro-healing phenotype. They interact with vein wall fibroblasts and myofibroblasts that ultimately produce the collagen and again the fibrosis. And so excuse me, one of the challenges with it is, again, the model is a mirroring model, which we think at least histologically recapitulates what we see in humans, and we have evidence for that. But it's not a model, none of the animal models at all have mouse rat standing, so you don't have that venous hypertension. So that's one of the things that any researcher is limited by, and how much a component that plays into the ultimate phenotype of the vein wall injury is not clear. Getting back again to your question, if we can again ameliorate the early inflammatory response or early midterm inflammatory response in the vein wall, that would be key. And again, if we can tilt the balance, again, potentially using nanoparticles or statins, colchicine or methotrexate, all of those have potential, as has been shown in the mirroring models, to attenuate fibrosis. So I'll give one concrete example where statins are certainly widely used for atherosclerosis and vascular inflammation. In the animal models, both by a researcher at Harvard and one of our past faculty here, showed that the statins can ameliorate or decrease vein wall injury and fibrosis. And there's currently, I believe, a larger clinical trial in Canada that may look to address this directly. So that would be really promising, or really potentially promising, because there's no other direct therapies that attenuate the vein wall injury.
Perfect, that's amazing to hear. And now, focusing on more innovative treatments, with the evolving landscape in both open and endovascular procedures, can you highlight some innovative treatments options for DVT and those that are currently being used?
Yes, so I think it's a pretty exciting time with regards to endoluminal therapies for the venous system. Typically, this has been done for years in the arterial system, and there's been a lot of refinements and improvements. And it's not to say that the venous interventions haven't been done over the last 20 years or so, but there are now venous specific stents that I believe are back on the market. And then the question still remains, despite the ATTRACT trial, is there a subgroup of patients who have iliofemoral DVT, very symptomatic, doesn't respond to anticoagulation rapidly, that would be best treated by a more aggressive approach to thrombus removal, so the open vein hypothesis. And so of decreasing long-term morbidity. And so there are many devices now that allow that thrombus to be extracted quite successfully without using 24 hours of thrombolysis, whether it's a caged type device to capture it or a suction device. There are numerous companies that make these. Then secondly, longer term is if it's occurred and the vein wall fibrosis occurs in humans, are there ways to attenuate that, either with a drug-coated balloon, anti-proliferative, or a drug-coated stent, maybe more applicable to, again, inhibit that fibrotic scar tissue that occurs in the vein wall after DVT. And if you look at patients who may have anatomical narrowings of the common femoral vein and you stent it, quite durable and low risk of thrombosis. Post-thrombotic veins tend to have the highest risk of thrombosis even after they're stented. So again, there's looking at ways to inhibit or thin out that tissue would, I think, be ideal long-term to reduce the morbidity of post-thrombotic syndrome.
Finally, since you have a lot of experience in the educational perspective of the chair of vascular surgery at the University of Michigan, a member of multiple commitments, what do you think vascular surgery training should be focused regarding DVT right now?
Yeah, I think, like I mentioned in the last question, this is going to be more and more surgeons, vascular surgeons, vascular interventionalists will be treating, I think, DVT, again, with properly selected patients more aggressively to remove the thrombus. So I think part of training, it always takes a little bit of the back seat, whether it's superficial disease treatment or more invasive deep system treatments are not as highly prized by the trainees as, an aortic aneurysm repair or a complex endovascular aortic repair. But it has to be included in it because, again, it is in many cases a more common disease process or occurrence than, aortic aneurysms, for example, if you take the whole population. So it's got to be an integral part of vascular fellowship or residency training, both with the treatment of DVT, because we get asked many questions on, can you stop the anticoagulation? What anticoagulation should they be on? What's the duration of the anticoagulation after a major DVT? So as vascular surgeons and specialists, we get asked that question a lot. What if it's in the setting of someone who's had a recent hemorrhage? Well, maybe the use of a filter then, which again is not always widely applied in training. So I think those things are important. And again, it's veins are vessels too, and we treat all vascular disease.
Thank you so much for your time, Dr. Henke.
Thank you.